I'm so excited to be back here. It's weird, but exciting at the same time. It feels like just yesterday when you walk in through the elevators, and yet I still got off on the 4th floor instead by accident. So I'm so pleased to speak with you today. My first few years at Trillium actually began at this site at Chantel's place, across the street in the hospital proper, as well as the child and adolescent mental health clinic. So I have a fond love for clinical social work, and that always stays at the root of the work I'm talking about. So excited to talk to you about this work, and also very open to a great discussion afterwards. So this conversation begins with empathy and what we think we know about empathy. And so years ago I started to think a little bit about where I wanted to head with my research, and I thought I'm going to figure out a way that we can teach empathy consistently all the time, and not just once or twice or every 6 months. And then I thought, oh, that's kind of out there. People are sort of doing that. Then I wondered about teams, because social work has been very special to me as both a professional and a personal value base, but I've always operated best in teams. Actually, it's nice to see some familiar faces, because I remember when I transitioned from clinical social work and decided that I wanted to work alongside our MBA colleagues and do some project planning. Kind of marched into the strategy office and said, can I and will you? And this great organization said yes. And so teams has always been part of the work. And so for decades, we've been actually talking about empathy influencing patient care and the experience. And we talk about how patients both receive and benefit from empathy. For so long, we've been talking about the importance in relationships, empathy in the caregiver relationship, empathy at home, empathy in the patient-centered design models. It's been there. We've been talking about empathy. Sometimes it's called communication. We've been talking about it in patient-centered models, Wordles. We've seen all kinds of frameworks. It's been there in great conversations and books, and many leaders who are already thinking about ways we can advance empathy thinking across a number of professions, including emotional intelligence. It's central for joining in meaningful discussions, engagements, and human significance, and always has been for me as well in my work. And then the conversation for me continued as I thought about interprofessional work. And to remind you, interprofessional work is really the work of where healthcare is moving for many, many years, and continues to move as we think about complexity, collaborative leadership, team functioning, and we start thinking about how care is characterized by the provision of healthcare services, multiple team members working together to deliver care to the same group of patients and families. In fact, we study models that help us design and influence care. Many such like Canadian models that are modeled after American models as well, that are around partnering with patients. And empathy is at the core of what we talk about. Yet it's not fully named. It remains important in a lot of our healthcare professions, including social work, and many of our allied health professionals. It's been studied with the physician-patient relationship over and over. And in fact, high-functioning interprofessional teams have been influenced by models of teaching, patient-centered design, and practice that kind of talk about empathy on the outskirts without naming it. So then I started to think a little bit about awareness, appreciation, and the intersection of empathy and interprofessional teams, its relationship to patient care and influence on healthcare and clinical outcomes, appreciating the existing meaning, significance, and of course empathy as described by clinicians. How would that understanding as described by those teams, how would that influence its application? And then it was important for me to understand how health teams communicated with patients and families in promotion, prevention, and treatment to improve health collectively. So I switched gears and decided to study empathy specific to interprofessional teams. Now this has been looked at in a few different ways. What's unique in this work is interprofessional teams function in the delivery of care, but they've never really been asked about how they describe and operationalize empathy. And I was interested to see if there was something that would help us prepare our teams better as part of their core competencies. So my feeling going into the work and the study was that in the absence of understanding the elements of empathy in an interprofessional setting, educators might be limited in preparing teams to develop empathy as part of core competencies. So what I position to you today is that empathy should, could, and might be part of core competencies. So then my dissertation study emerges, and the work I completed was constructivist in nature and context specific. So I looked to explore for whether not only did it exist, but could there be a theory that models how interprofessional healthcare teams both conceptualize and operationalize empathy in their practice with patients and families. And this was really interesting for me because I know that I wanted to recruit members to participate in the study together as teams. And those of you who have had the pleasure of doing that great work of recruitment and research know that that can be difficult. But it was crucial to the study. So here's the framework. Two influences coming together in this structured approach. One was Baird Leonard's very well-known cyclical phases of empathy. Empathy has often been talked about in the context of many different frameworks. This one in particular starts with what's described as a cycle. Listening openly, resonating back what you have heard, expressing that, and then knowing that the other person has understood it. And that cycle repeats itself. So that's the empathy cycle phase that I use to influence the structured approach. And then theory of planned behavior, because it is my position that empathy can be intentional, cultivated, and then becomes natural at some juncture, and then we repeat that cycle. And that we can control and influence actual behavior and intention. So these approaches actually in particular, they served as the foundation, and I looked to start thinking about consolidating perceptions of empathy along with operationalizing the definition. So a little bit more about my questions and what I'm going to talk to you about today and where that led to. I was interested and continue to be very interested in how interprofessional teams conceptualize empathy. So how do they describe it, talk about it, give it meaning? And then how do they do it? Their practice of empathy in patients and families, and how do they do it together? So lots of information and research out there about how social work practices empathy or learns about it, how physicians do, how nurses do, how many of our allied health professional colleagues do, but not a lot about how teams together describe it. And then I was particularly interested in what are the elements and could there be the emergence of a theory describing empathy in interprofessional teams. And what I discovered was both inspiring and inspirational for me. So 24 hospital-based healthcare professionals from Ontario participated in this study, including dietitian, social work, nurse practitioner, physio, OC therapy, speech language, and recreation. And there were a number of healthcare teams: diabetes, geriatric, mental health, orthopedic, rehab. What was interesting for me is when I put out this study, I had, within 48 hours, had over 66 participants put up their names to participate in teams. While I want to say that was about me, I know it wasn't. It was a lot about people wanting to talk about empathy and in a medical setting, talk about a non-medicalized opportunity. And so findings, this is the exciting part of where we're going to focus most of our conversation today. 3 elements came up in this work under the heading of conceptualization. So I asked about descriptors. How do people describe empathy? And the first one is symbolic attributes. So empathy's got many facets, varying definitions in healthcare. We all learn about it a little differently. We all describe it a little differently. But it was really important to acknowledge the team members' descriptions of empathy. Not only did they have their own descriptors, but they felt that to operate within a team environment, they also needed to adopt descriptors ascribed to by their teammates. Common attributes included validation, compassion, and some kind of mindful union of body language and words. The second descriptor under the conceptualization was around deep personal experiences creating meaning. So empathy is a deeply personal experience. Sometimes hard for us to say that out loud. And the large majority of participants actually conveyed their first memories of learning about experience of empathy was not at all in healthcare or even nearby. as children in their home or in their upbringing itself. And that empathy appreciation was actually solidified by personal experiences over time. And that resonated far more than didactic learning. So I'll tell you a little bit about that momentarily. Thirdly, purposeful perspective taking. And this has been in the literature in different ways, that rapport and trust are often affiliated with empathy as an enabler for delivering care, and that a decided and intentional act to try to imagine a patient's perspective or to join in their emotional and cognitive level was purposeful in their perspective taking. And this came out. Here's a little of what I heard under symbolic attributes. Borrowing an individual's experiences, their feelings, and their situations to support them. Treating them with humanity, understanding is really important. Sensitivity to someone's body language, people's needs, and meeting them. Warmth, and of course it's just listening and understanding what the patient is going through and validating that. A little bit about deep personal experiences. This is one about learning about empathy outside of healthcare. Experiencing poverty or seeing poverty. A mother or parent intentionally teaching about empathy. Taking care of a grandparent came up often. How I grew up. Experiencing loss, volunteering, canvassing. A few folks mentioned their experiences with UNICEF as a child and trick-or-treating. How your parents interact with you, and in fact how they name your emotions at home. Purposeful perspective taking, imagining someone in someone else's world, walking in their shoes, understanding emotionally, just being there in that person's shoes, tapping into how you might feel. And so we've heard this before, walking in their shoes, putting yourself in someone's perspective, taking a moment from their thought bubble. It's hard to do. I'll come back to that in a moment, but I want to share with you under operationalization. So you'll recall I wanted to look at descriptors and descriptions and conceptualization, but I also wanted to look at action and how people actually implemented empathy together as a team. So the first descriptor here, 3 as well, again, the first is team behaviors influence clinical outcomes. Empathy is a mechanism for creating patient adherence to treatment, elevating motivational levels, and ultimately influencing patient satisfaction. Improving clinical outcomes is a team responsibility, so the theme of facilitating this to engage purposeful activities as a team. Being very aware of unbiased language, avoiding medical jargon, and creating a physically inviting environment. And then interprofessional practice emerged as an enabler for quality of care, which was often tied to empathy. Secondly, as a collaborative engagement, empathy. So no single member can deliver empathy in isolation if you're part of a team. In fact, the theme that came up over and over was that it's important to seek innovative ways to stay connected and being sort of cognizant of patient issues and being respectful of the differing views. Team members can learn from sharing personal and professional experiences. So this was a nice, surprising light bulb. The folks felt that by sharing some of those deep and personal experiences in the confines of safety with one another in a team environment might actually help them build rapport, support, and be more empathetic. And of course, you won't be surprised to hear that as part of that theme I just talked about, empathy with one another was tremendously important. So intra-professional empathy. Thirdly, empathic intent. So intention can be explored as some concept of action and desire. And that was true for empathy as well. Having the intention of positivity towards a patient could lead to better listening, deliberate ways to be empathic. Folks talked about body language, eye contact, the ways in which they broke bad news. Disciplines often require specific intent to work in healthcare, and so empathy being captured as part of that intent could be cultivated and part of a teaching mechanism to foster. And then finally, empathy can be explored as an interprofessional team competency. Here's a little of what we heard under operationalization. So I heard talk to each other each day, huddle in the same space, daily rounds, team building, coaching, building a common language. And if we could be empathic together, we could maybe create a future plan for the patient. So much of what you're already doing in terms of team-based spaces already. Empathy is a collaborative engagement. So this theme was really around switching from case conferences being work to do or team communication being work to do, but really starting to think about collaborative engagement as an empathic opportunity. So a big part of our jobs focusing on patient strengths, but could we focus on our collective strengths to deliver better care? Trusting one another and having open conversations. Seeing it as a team sport and having empathy for each other. And this is where the intrapersonal empathy really came out. Some great examples of this that emerged were the opportunity to actually intentionally talk about difficult patients, resistant to care, or caregiver distress in a totally different way, and to think about a collective way to demonstrate empathy one after another or in the same clinical interaction as a team sport. But that required intention. So empathic intent, this was an interesting one because it really emerged through a lot of different, it emerged through all the other elements that you could actually actively want to be empathic, and you could choose to be empathic as you could choose to be disengaged. You could show that you understood. You could not only understand what they were presenting and telling, but you could look beyond that. It's the ability to have engaged detachment for some. It's not even about what you say. Sometimes it's not anything that you say at all. Being authentic was a consistent theme, that empathic intent and authenticity could actually live in the same space. So here's where it came to. So I looked for elements, both in descriptors and conceptualization, that allowed for the relationship between the two and interprofessional teams to be explained. I looked for what space exists in this work that was both valued and demonstrated. And then lastly, I was interested in if there was prerequisites for empathic centered care in some way. And here it is. I want to come around, but I realize you have to stay in this spot. 6 elements in 4 main constructs. The first one is empathy as a team is valuable. Plain and simple. The second is empathy is not accidental. You don't fall upon it. You weren't born with it. And if there was some opportunity to nurture it, you could cultivate it. And this is the controversial opportunity to talk about. Empathy amongst interprofessional team members is a prerequisite to clinical empathy with patients. So this is that concept of empathy with each other, increases empathy in your clinical care, and genuine intent is vital to the empathy relationship. So what you'll see in what I describe as the interprofessional intentional empathy-centered care model, or IPIECC, is 4 constructs, and those 6 elements that we just talked about are built into those constructs. Empathy as a team being valuable is really around those symbolic attributes, adopting not only your personal language around empathy, but also the language of your teammates. Empathy not being accidental was really around pulling on the threads of learning from your deep personal experiences that created meaning, and then also taking purposeful perspective taking as a team and discussing that. And then the prerequisite was really around team behaviors that influence clinical care, and then collaborative engagement around empathy. And lastly, the intent and genuine intent being vital was really linked to the descriptor around empathic intent. So linked in a slightly different way, just pulling out the 4 constructs against the elements. I want to take you a little bit through how this could translate to practice and what we can think about when we think about empathy as a collective engagement. It's a little different than empathy with one another. I think one of the most interesting moments for me is that there is literature that points to emotional intelligence and the overlap in this work, and lots of literature that supports team building requiring effective communication layered and laced with empathy. But its translation to practice sometimes has been overlooked because it's not necessarily been described as a core competency. So we have interprofessional collaborative care models and practices and frameworks that we adopt in how we deliver high quality care. And in fact, IPE sessions are marked by our WHO description around our World Health Organization around caring with, for, and around each other and learning in that way. Intentional empathy-centered care then has the ability to adequately raise the expectations of those frameworks, to name empathy as a possible measure of quality. And so then if you could name it as a competency, then down the road could we seek out and search for empathy as part of applications both to jobs, to professions, to team-based care. Something we often loop into communication for now. Findings in the study also extend the literature in a few different ways. The potential for this particular type of theory explains how teams could approach cultivating empathic intent through team behaviors, the ways in which they communicate, changing the ways in which they huddle, thinking about approaches to future planning, care planning for teams, thinking about advancing and adopting empathy approaches, and for a mindful way for leaders to be involved in that. No doubt when we talked about collaborative engagement, what came up over and over was that healthcare environments needed administrators that supported this competency as part of core practice. Again, empathy is not accidental. So what comes out of this work is that there's the ability to match intent, behavior, action with good, amazing team building and discussion. And that is not something you fall upon accidentally, that it's intentional, that there's space set aside for that. It's sort of the emergence we've seen as we moved from quality huddles or transfer of care at bedside and things like that to actually involving our allied healthcare professionals in those discussions, to hearing from social work, physio, and or occupational health around how we could move through transition, discharge, and planning together. Empathy amongst the interprofessional team should be discussed, honored, and cultivated. Because there are many of our colleagues and professionals that may not see it as a hard skill, that may not see it as something that we talk about. And so this is where safety, support, team building, emotional intelligence intersect with this work. Empathy as a clinical skill should be known as an expected competency in healthcare, not seen as just her job or his job, or frankly, let's just refer to the social worker. That as a team-based model, I position that you could actually move through elevated levels of patient adherence to outcomes. So where I'd like to see this work take shape in the future, the space in which empathy can be interpreted, maybe valued. It can be complementary to interprofessional teaching and intentional practice. So it becomes part of the discussions when you think about interprofessional care, when you think about collaborative care models, when we think about partnering with patients. Well, when we talk about partnering with patients, we don't often talk about empathy as part of that as a core competency. And I would look to seek to find opportunities to apply the identified learning in some practice of empathy that could be actually measured and delivered in a healthcare setting, that we might screen for, that we might look for, and that we might try to measure. No surprise when I go back to the, you'll notice in in the findings, the participant sample, there's one key colleague group missing. It had a really nice cross-section, didn't have any physicians. They were asked, but I suspect strongly we have some movement to make around how we move together as a team, who we see as part of the team. I have amazing physician colleagues that I have worked with who would value empathy, but maybe not have a space created to talk about it intentionally in this way. So I'd like to see the study repeated with our physician colleagues and just starting to think about that a little bit. And it's often not seen as a traditional physician role, right? Few theories actually link learning methodologies to empathy specifically, and so we can start to really relook at that, especially in the emergence of emotional intelligence and a great space for team building. And then we can also start to think about how the application of a theory like this could be included in research studies that screen and recruit based on key skill sets. And naming empathy as an important attribute and not just a soft skill. And the findings, of course, support the opportunity for interprofessional education, teaching, learning, and practice to actually be taught, and curriculum to actually be designed around empathy learning. So I'll just pause there for any questions before I go on to one final piece. Yeah.
Thanks so much. This is a terrific presentation. I'm just curious about some of the method stuff. And were you recruiting individuals to talk about their experience with their teams, or were you recruiting teams so that you could actually look across teams?
Yeah, I can talk about that. So, kind of where I was going to take you next anyways. When I first designed the study, I wanted to just do a series of individual interviews and was very open to sort of a narrative style or, you know, a traditional qualitative method otherwise. But as I really looked at the design of the study, I couldn't really capture the team element that way, nor did I create a safe space for folks to talk about the strengths and or challenges and opportunities of their teammates. And so the recruitment required at least 3 different professionals who worked in a team-based environment to come together for one focus group, and then for them to be individually interviewed. So that was a bit of a logistical nightmare, frankly speaking, because you not only had to talk to your teammates about wanting to participate in this study together, you then had to find the opportunity, and you had to have worked together for at least 6 months, because how would you be able to really talk about your team work? And you had to be working in an environment where you were delivering care consistently to a patient population like diabetes or geriatric mental health. So what makes that complex is you can often find 2 professionals, but sometimes a social worker, dietitian, or occupational therapist is the person that floats in and out across several environments. And so that was unique to the study, and still I had that many participants find ways to come together. So to answer your question, it was qualitative in that way that they had to come together for a focus group, and then post focus group actually individually interview, and then it was something like 6,000 transcript pages that we checked against what they. I say we, but it was really me. I was reading them all. There's that team piece, I guess. And I checked their themes against what they had said. So.
Thank you.
Was there any of the individuals in your or participants really talked about some of those purposeful structures that are working within their environments? Because you talked about those pieces.
Huddle boards came up. Funny enough, obviously I'll just name, it was a conflict for me to do the study in this hospital, so it wasn't I didn't have any participation here, but it was really neat to see the concept that I had sort of grown up and near, which I thought was, you know, maybe new and innovative, was starting to spread and adopt. So absolutely the idea of coming together frequently with carved out time. What they named as, what was actually more interesting was naming what didn't work. So not having carved out time, not having space to talk with one another, and not having safety to challenge one another on how to move patients through the system and their families posed as difficult. And then medical jargon. So really, really addressing ways to sort of call each other on labeling patients and families, calling each other safely in a space to move ahead and move forward from discharge planning to care planning, and just really thinking differently about collaborative movement, and certainly challenges with hospital capacity came up over and over. And so how do you raise something that still feels like a soft skill for a lot of folks in an environment where you're really focused on moving patients through the system and being at capacity and gridlock and things like that. And so what came up over and over is actually baking in empathy as part of a core skill would change that perception, and rather than an afterthought. The topic of diversity also came up, so both diversity from the perspective of diverse representation on the team of disciplines, but also folks who could see diversity amongst the representation of their team members across the hospital would reflect their patient and family populations, and that just naturally elevated elements of empathy that they could speak about more openly.
So in your data, were there discussions around empathy as a gendered construct?
Oh, yes, and as specific to a profession. So
Yeah.
over and over the theme of empathy being seen as the social worker's role came up. And you know, it was really interesting when I did focus groups. Teams felt safe to talk about a lot of this, but you can imagine that quick rapport that was built with myself as the interviewer and the participants. It carried through the next discussion when we had individual conversations, and it didn't take very long. And so I could almost close my eyes and know who the social worker was, and so that was even there for me. So I think about my own bias in the research, and so I could know when someone was valued on the team for having those very difficult conversations, and I could also tell when some folks were left out purposely out of the discussion. Absolutely came up as a construct of being much more available, intuitive, and natural for women. Mm-hmm. And the same sort of construct came up when physician conversations also came up around not being seen as their role. However, I will say an interesting and an enlightening moment was folks really describing that they had seen the evolution of their physician partnership really change in the last several years. And there was a real team protectiveness, our doctor would have come, however, the timing and/or. So there's something there for sure.
Just building on Liz's question, and thanks for the presentation, that's really great. Talking about the physician is missing, I was just wondering what the gender distribution in your sample.
Yeah, well, I left it out because it was 23 females and 1 male. Who knew he was the 1 male? Yeah.
Thanks. Anybody else?
So do we have maybe explore the idea of introducing empathy as a possible operational concept earlier on in someone's career before they actually go into a healthcare space and start working, probably in the medical, medical schools or whatever programs they need to become a healthcare worker.
Yeah, so the idea of introducing empathy as a construct early in their career, that definitely came out because it came out, for me, I think the largest surprise was definitely around intent and empathy and the viewpoint so strongly around that, but also around nobody describing their first experiences of empathy ever being in the healthcare setting. In fact, I had people even talked about object empathy, having empathy for their favorite sweater was their first learning, or the moment that, a grandparent entered their lives and they were living with them, and then there were elements of diversity, culture, and language that they learned. And so what has not been created is a space to actually talk about that as part of your didactic learning. So when we start to learn empathy, and I could talk about our social work profession, it is the day you come into class, and today we're talking about empathy and what it means, and the next day we're going to talk about how to demonstrate that, but not really talking about where those constructs already existed, and that you actually learned the true elements of body language, description, trying to take perspective long before that. And when we raise that, what happens is we are seen as blurring the boundaries. Between personal and professional. So I don't think that space is always created. I don't actually even think it's necessarily always created in the academic social work environment as well. We often talk about healthy boundaries and how to have conversations. And so I'm positioning in this model that in a team space that could create that, the same team environment that holds, wedding showers and baby showers and celebrations, we cross into a personal realm that feels comfortable. But why is it not part of our case conferences to talk about our challenges with empathy? Does that answer your question?
Yeah.
I'm curious, near the end you mentioned that it could be a recruitment criteria variable that you're looking at, and one might imagine that empathy could be something you're looking for amongst an interprofessional research group or that kind of thing. So how would you articulate questions where you're trying to have someone elicit their ability to have empathy or intent, that kind of thing?
I'd look for behavior and intent matching. I'd be really interested in sort of drawing on the theory of planned behavior kind of as a construct. How do people set out to be intentional? Because it came out in the study that before I entered the room, I would take a deep breath. That's intentional, right? Or before I saw certain patients and their families, I would meditate for a few seconds. Or sometimes I would make sure I had my favorite Starbucks drink before I went in. Those are all intentional acts to ground yourself so that you can join with your patients and families. So I'm very interested in how intent could be drawn out in some kind of questionnaire and or screening or interview process. And we do it in our behavioral questions. We look for some kind of intent in action, but we're not looking for empathy. Right, we're looking for a skill set there, right? A different skill set.
Thank you.
Yeah.
So this is just such an interesting presentation and just great research. I'm wondering, like, do you have concerns about empathy becoming part of a checklist? You know,
Yeah.
like what you're talking about here is like something deep and intentional, thoughtful, grounded in theory.
Yeah.
But then, you know how things go in healthcare, we develop buzzwords.
Yeah.
And so what are your thoughts on how to sort of...
I do. I think about this all the time because when I first, my first iteration of this particular, the intentional empathy-centered care model or theory was actually to remove anything about deep personal experiences because I really worried that would cross into non-core competency level skill thinking. What put that back in there was that obviously my participants told me loud and clear. And secondly, I think that is what will anchor it in being able to be realistic because you can't really attach constructs and number and boundary to personal experiences, but you can actually create some boundaries around safety and support. So there's lots of literature around creating team safety, creating support, having a good administrator or a leader, mentorship, coaching, peer review and feedback. Baked in there is your opportunity for deep personal experiences, and that's where I hope it stays rooted in that. But yes, I do. And we've been talking about a lot, there's been lots, Brene Brown and some great TED Talks, like this is there, and so I think when we talk about healthcare, it's now talking about it as a core competency as part of your entire skill set. And that it can be learned and cultivated over time, and it changes faces as is your other skills. So I'll say where I'm at this point. Couple of things is I'm just looking for an opportunity to repeat the study. And I'm, of course, wanting very distinctly to think about our physician colleagues and partners. I think we have this really unique opportunity to possibly, this was an entirely qualitative piece of work, but to think about matching that with a mixed method of sorts. And I'd be interested to see if the teams that stepped forward were naturally solid teams. It's hard to know that. They were, a mix of diabetes teams, geriatric teams, that had they already been trained to cultivate some of this. So what would it look like for a team that had just newly formed or has been together for a long time? So I'm quite interested in that. And so lastly, before I open up for some final questions, I don't ever really talk about this work without some quick acknowledgements. Of course, my chair, and specifically special acknowledgement, believe it or not, I give this wherever I go, not just because I'm here, but the colleagues I worked with around and near during my clinical work at THP really influenced my work and my decision making. And of course, acknowledging the great scholarship funding and support I had early in this process from here, and patients and families who allowed me to be near them in their worlds. And I would be amiss if I didn't make a shameless plug for the fact that Social Work Week is coming up in March, and this week's theme is leading positive change across systems and settings. So reach out to a social worker and remind them that they're valued. I have this great role where I get to talk about the voice of the profession every day, and so I want to do that today. And then my last acknowledgement is to the two girls that gifted me time to get through this work. It's the roots of where empathy originates for me. It's my little bear and star. Thank you.